Hi everybody, welcome to the January 17th half-day talks. I'll be going over glenohumeral arthritis, and in this podcast we'll be looking specifically at the physical exam and imaging. So thanks to Dr. Lowe and Dr. Bois. So our objectives are, as I just stated, so physical exam and what you would find on imaging. So we'll start with your physical exam. So there's no specific exam maneuver that you can do that will diagnose glenohumeral arthritis. So generally you want to look for things like loss of range of motion. So likely it's going to be decreased, and your two areas where it's most likely to be decreased is forward flexion and mainly external rotation. This is due to a tight anterior capsule. And then, so other than pain during range of motion, also passively when you take them through their end range of motions, that it will likely be painful at that point as well. And then you do want to do a full shoulder exam to kind of elucidate the etiology of their shoulder pain. And if it is glenohumeral arthritis, you still want to do your special tests for rotator cuff pathology, labral tears, and etc. Keeping in mind that these different pathologies can lead to OA as well. So moving on into imaging. So really it's an imaging diagnosis. So you're going to start with x-rays as the gold standard. So you want orthogonal views, so AP, true AP, the glenohumeral joint, and you want axillary view, and you can get a scapular Y view for what it's worth. So your findings, so generally in osteoarthritis, like any other joint, you want to look for joint space narrowing, subchondral sclerosis, subchondral cysts, and some specific findings to the shoulder. You can look for an inferior osteophyte, which is called the goat's beard. You can see the angle or the arrow pointing to it there. And you could look for a greater, or for GT osteopenia, as well as a humeral head flattening. And so imaging is going to be your best friend in this diagnosis, and usually you can see the etiology on your imaging. So for primary osteoarthritis, these are two pictures. So you got an AP and a axillary view showing some osteoarthritis. So things you're looking for, you can see some joint space narrowing there. You can see the goat's beard at the bottom, and you can see some subchondral sclerosis. So pretty classic findings of osteoarthritis. So another one you can diagnose on imaging is rheumatoid arthritis. So they're going to have a story of a painful shoulder. It's going to examine like an arthritic shoulder. They're usually going to have fewer osteophytes on x-ray. They'll have marginal erosions, and they'll usually have marked osteopenia as well. So you can see those findings in that AP there. Osteonecrosis is another etiology you can diagnose straight off x-ray. So early in this disease process, if you're seeing them for a painful shoulder, it may be normal x-ray findings, but as it progresses, you can see humeral head collapse and resorption of the middle of the humeral head, as well as other findings such as osteophytes and sclerosis if they've had prior trauma as well. Another one, post-dislocation arthritis. So typically these people have a very large osteophytes. You can see the very large goat's beard osteophyte at the inferior border of the humeral head there, and you may also see previous pieces of hardware in their shoulder from stability surgeries. So that's kind of our run through of x-ray findings, and then higher level imaging such as CT and MRI. So you shouldn't really need this to diagnose glenohumeral arthritis. You should really get that off your x-ray, but it is useful for examining the joint in greater detail, and you can look for contributing soft tissue causes on MRI specifically, such as rotator cuff pathology, labral tears, osteochondral defects. And it is also a lot more useful than x-ray for preoperative planning if you're looking into doing total shoulder arthroplasty or something like that. So we've gone through the imaging, and is there a classification system? So yes, there is a classification system. So it's the Walsh classification. So this was used to describe the glenoid deformity in primary osteoarthritis initially. And initially this was described using only x-ray. So it's been updated to include CT findings as well. So the study from the Journal of Shoulder and Elbow Surgery from 2018 showed that there was good intra-observer agreement using the modified Walsh criteria. I showed that their intra-observer agreement was substantial on the diagnoses. So there's the classification system at the bottom there. So there's 4 types, type A through D. So A is concentric wear with no subluxation, and then there's 2 parts of that. And then type B, so it's biconcave glenoid with asymmetric glenoid wear. And then type C, you're getting into a retroversion and as well as a bone loss. And then type D is anteversion. So you can read that classification system there. There's also a picture of it, so you can see type A at the top there. So type A1, it's centered on the glenoid, and then A2 there, that blue line is showing kind of where the surface of the glenoid would be. You can see that deep central erosion there. And then type B, you can see retroversion and posterior subluxation. And then type C, you can see increased retroversion to greater than 25 degrees. And then type D, you can see any anteversion. So it's just a quick picture overview of the watch criteria. So in summary for this short podcast here, so physical exam, no specific tests, so loss of range of motion, specifically external rotation is probably your most sensitive test, I guess, for glenohumeral arthritis, but really you're going to diagnose this disease on imaging. So X-ray is going to be your go-to, and then higher level imaging such as CT and MRI is useful for preoperative planning mainly. All right, and there's my references, and thank you for listening.